All right, welcome back. This is probably one of the more confusing topics for what will turn into one or two board questions. But if you know it really well, you'll do great on it. So this is hemoglobinopathies and thalassemias. So we'll talk about kind of basic globin chain knowledge, what the hemoglobins are from these problems. We'll discuss more in detail about thalassemia. I know Dr. Gowans gave you some overview stuff about what that means to be thalassemic, clinical characteristics, differences between alpha and beta thalassemias, and then we'll talk a bit on sickle cell disease as well. So hemoglobin, right? So it's a combination of globin proteins that complex with heme and iron. And basically there are alpha types of these things and beta types of these things. And then the beta types, there's a couple different types. So you can have the typical beta. So you have alpha 2 plus beta 2 gives you a hemoglobin A. This is adult type hemoglobin. It's what most of us have. You also make a little bit of a beta type hemoglobin called delta. So you have alpha 2 plus delta 2 gives you hemoglobin A2. So we all have a little bit of that. And in fetal development, instead of making the beta or delta, you make gamma. So if you have alpha 2 and gamma 2 in utero, that gives you fetal hemoglobin, or HbF. And so you can have mutations in these things that cause problems. And so if you have a single point mutation in one of the beta globin genes, you can have a sickle beta or beta S. You can have a mutation in the exact same spot that causes a C or beta C. And then you can have mutations that don't change the structure of the globin, but change the production of the globin. So these are the thalassemias. So when you don't make enough of the betas, that's how you get beta thalassemia. And there's kind of two forms. So there's a beta plus, where you make a little bit of normal beta, and then a beta naught, where you produce no beta. And so again, if you have these point mutations that make a sickle beta, if you have alpha 2 plus 2 of those beta S's, you get hemoglobin S that we see in sickle cell disease. And then if you have that complex with the beta C, you can have hemoglobin C. So I'll start with thalassemias. So these are really a very diverse group of genetic diseases. It's the most frequent genetic disease seen worldwide. The incidence is potentially going up in North America. And it's a little bit geographically and ethnically limited. So we see this many times in patients of African ancestry, Chinese, Mediterranean, and Southeast Asian. And then the alpha and beta thalassemias are named for which globin is not being produced normally. So if you have alpha thal, it's because you're not making the alphas, beta thal, you're not making the betas. And basically the way this works is you're not making enough of whatever chain that is, and so then you don't make enough of normal hemoglobin, and then you end up with less hemoglobin in a red cell. Less hemoglobin means you're hypochromatic, and those cells tend to be small and microcytic. And a lot of the disease is not necessarily because you're not making the normal, but it's what you are making instead. So if you don't make enough beta, you make a lot of these extra alpha tetramers because there's too much alpha floating around. And these alpha tetramers are really insoluble. They precipitate in the red cell precursors. They cause ineffective hematopoiesis. And then the beta situation, so you're not making enough alpha, so your beta is all complex together. These are increasingly insoluble with red cell age, and so they cause damage to the red cell membranes, and the red cells hemolyze very frequently in the spleen. So our first question here, if you can remember from 3 seconds ago, so the ineffective erythropoiesis is more common in what? Like 50-50. Oh, good, pretty good. Right, so I'd be surprised if this ever comes up, but the answer is, the answer is B, the beta thalassemia. So again, that alpha 4 tetramer tends to be problematic to the red cell precursors. All right, and then elevated hemoglobin A2 and hemoglobin F lessen the severity of which disease? Lead poisoning, alpha thal, iron deficiency, B12, or beta thal? So who's got elevated A2 and F? All right, pretty good. So this is going to be beta thalassemia. So we'll talk more about this as we go. So the first slide here is going to show a little bit about what normal globin synthesis looks like. So you've got a lot of alpha globin and a lot of beta globin inside each red blood cell. They combine together, they make hemoglobin A, and you've got little bits of delta and gamma floating around. In the case of a beta thalassemia, you don't have enough of that beta. So again, the mutations are causing not enough beta to be produced, and so your alpha and beta try to combine, but what you end up with is some leftover alpha pieces. And those alpha pieces might combine with the delta to cause A2, and they might combine with gamma to cause fetal. And so if you can try to remember how this works a little bit, helps you answer some of the questions. So thalassemias, there's a wide range of severity. They can be severe, they can be mild. When it's severe, typically this is a chronic anemia. The tissues are chronically hypoxic because not enough oxygen carrying capacity. The bone marrow tries to compensate, it expands, and you can have skeletal changes from that. You can have cardiomegaly, again, from poor oxygen and trying to get oxygen out to the tissues. And then the body thinks it's being starved of iron even though it isn't. And so one of the big problems we see in severe thalassemias is you get iron overload. Your body's constantly trying to absorb iron even when you're not iron deficient. So specifically beta thalassemia, so we see this around the Mediterranean Sea, in Africa, more so northern Africa, Southeast Asia. There's many different mutations you can see, and again, depending on which mutation depends on how severe it is. And again, there's a very diverse phenotype from asymptomatic carrier state to severe disease. Like most genes, you have two copies of it, one from mom and one from dad. And then you have a mutation in the beta globin gene, and that gives you decreased or absent production from that particular gene. And how much beta you make dictates the severity. So we look at this, we get blood counts, a retic, make sure it's not iron deficiency, we'll talk about that. And we usually do a hemoglobin electrophoresis. And so the way we categorize this depends on, again, which mutations you have. So you can have, just a little bit decrease, which is like that normal beta plus a beta plus, or you can have absence of all beta, which is like two of those beta not mutations together. And at the end of the day, what you end up with is a minor or a trait situation, a major disease situation, and then this weird gray zone called beta thal intermedia. So with trait or minor, you just have one gene involved. So it could either be a normal beta with a beta plus or a normal beta with a beta not. Overall, you make not enough beta and then not enough normal hemoglobin in the red cells. You get usually very mild anemia or no anemia. But with that, your body tends to make extra red cells. So normally there's a normal or elevated RBC count. So the classic situation, again, is microcytosis with a high RBC. And the microcytosis is usually pretty profound. These numbers may be down into the 50s with a near normal hemoglobin, so it's out of proportion to what you might see with iron deficiency, which is usually much less microcytic. We would typically see an elevated hemoglobin A2, sometimes F, and again, this we would see more likely in African Americans. Mild disease versus Mediterraneans tend to be a little more severe. That's clinically asymptomatic in the minor situation. So really the most important thing here is not to mistake it for iron deficiency. So this happens all the time, that, especially if you just check a hemoglobin sometimes, it'll come back a little bit low, and your gut instinct is to put these patients on iron, and then it doesn't get better, which is how they end up in my office. Or even if you get a full CBC, they're microcytic, they're hypochromic, they look iron deficient. So again, patients that aren't getting better from iron supplementation, it's really important to make sure that they're truly iron deficient and not a beta thal minor, because those patients we would just observe. The peripheral smear, in general, is microcytic, hypochromic, and occasionally you'll see these little target cells. In the more severe type of this disease, so beta thal major, so you've got two beta genes that each have a mutation, and it could be two mild mutations together or potentially two severe mutations together. Again, in the beta types, there is ineffective erythropoiesis. These patients will hemolyze, and there's usually a pretty severe anemia that tends to present by about a year of age, typically less than a hemoglobin of 6. They're very microcytic and hypochromic. You might see a lot of nucleated red cells. And when you do the electrophoresis, you'll see that A2, you'll see the fetal hemoglobin, but because they're not making really any beta, there should be no normal hemoglobin A. So if you have some hemoglobin A, really takes the major off the table. And again, it's similar to the other slide, but it's a little bit more chaotic and more fragmented forms. So really what we worry about is the major beta thalassemia. So again, you get bone marrow expansion, they can have bony deformities, they have growth delays. You may get extramedullary hematopoiesis. So in extramedullary hematopoiesis, you can have tumor-like lesions of hematopoietic cells trying to compensate for this. And actually, we just transplanted a girl with beta thalassemia about a year ago, and we had to get a chest CT because she was febrile. And the radiologist called us. They were worried she had a cancer in her chest, and it turned out it was just hematopoietic tissue from her thalassemia. They tend to have massive splenomegaly, and then they're transfusion dependent. So if you don't transfuse them, they don't survive. And so again, if you don't do anything, usually by age 10, this current standard of care is we will try to transplant these, and then there is emerging gene therapy in the works. So this is what these patients will look like untreated. So the child on the left, you can see frontal bossing, the maxillae are prominent. On the right, this is a really classic x-ray, so they call this hair on end sign. So basically these little strands that look like hairs is just the medullary space that's very, very thick in the scalp. And then outside of the severe disease, there's this, again, gray zone we call beta thal intermedia. So they produce a little bit of beta. It's usually enough to get by, but they still have some problems. So they're moderately anemic, down to around 7. They may need a transfusion once in a while, but not always. Similar electrophoresis pattern where you'll have the elevated A2. And similar to the severe patients, they may have delayed puberty and heart issues, osteoporosis, arthritis, bony problems. So it's not necessarily a benign disease, but often we don't have to be as aggressive with therapy. Shifting over to alpha thalassemias. So again, this is a decrease in alpha globin production. And so what you have excess of is excess gamma in the newborn. And when they form tetramers, gamma-4 tetramers, the hemoglobin BARTs. And so you may get this occasionally on newborn screens. They'll tell you a possible hemoglobin BARTs. It really much tells you there's going to be an alpha thal of some sort. As the child ages, the fetal hemoglobin stops getting produced, and you start making more betas. And so you may have excess beta tetramers, that's hemoglobin H. This is very prevalent in Southeast Asia, Malaysia, and southern China. What's really interesting about the alpha globin locus is it's duplicated. So instead of just having 2 genes that can be messed up, you can have 4. And how they inherit depends on where the genes are. So this one's a little bit more complicated. So again, the severity of the disease absolutely is linked to the number of genes that are broken. Similar to the beta thalassemia, you want to start with the same workup. Look at the blood count, look at the reticulocyte count, make sure there's no iron deficiency, make sure it's not beta thalassemia. That's an easier one to do with the electrophoresis. And again, if you see that hemoglobin BARTs on the newborn screen, it's made at least a categorical diagnosis for you. But really the way to know how many genes are gone is to do genotyping. So we actually can send panels to look to see how many of these genes the patients have. And so the way you read these is that, again, you've got 2 different loci for the alpha gene. So each little dash there is a deleted gene. So you can have 1 gene deleted, you can have 2 genes deleted, but that 2 genes could be within the same locus or 1 gene on each locus. You can have 3 genes deleted or all 4 genes completely absent. And again, this clinical spectrum depends on how many you're missing. So because there's 4 different possibilities, you can either be a silent carrier with no symptoms, no findings. You can have a kind of trait or minor situation. 3 genes we call hemoglobin H disease, and 4 genes is alpha thal major. So again, one gene missing is a silent disease, so they really shouldn't be anemic. They minimally could be microcytic, but usually not. And really the importance for this is that you don't get it wrong on your board exam. So if you have 1 gene, the answer is asymptomatic silent carrier. 2 gene deletions is what we more commonly see in the clinics. These are trait or minor patients. So they're mildly anemic, they're hypochromic, so it can look similar to beta thal minor. So again, the question is, how do we tell those apart? What's important on the alpha thals is where those deletions are. So if you have 2 genes missing at the same locus, it's easy to pass that on to your offspring, whereas if you're missing 1 at each locus, it's less likely you're going to pass on severe deletions. And there's a little bit correlates in terms of the ethnicity. So the Asian type tends to be what we call cis deletions, where they're missing both at the same locus. The African type tends to be the trans deletions missing on 2 different loci. Again, job as a pediatrician, once we make a diagnosis of this, 1, don't treat with iron, but number 2 is we do refer these patients for genetic counseling. So again, especially if they have that cis form and their partner later in life were to also have an alpha thal gene deletion, a much higher risk of having severe alpha thal in children. So when you get up to 3 gene deletions, this is hemoglobin H disease. Again, you're making extra betas. Those beta 4 tetramers are hemoglobin H because you've only got one functional alpha gene working. Beta 4s are soluble in the circulation, but they do hemolyze, and especially with red cell age, they hemolyze more. If you get a virus infection, some sort of oxidant exposures, all of this can trigger hemolysis. So these are patients that may not need transfusions all the time, but under certain periods of stress may. Predominantly Asians, again, because they tend to carry that cis deletion more commonly. The phenotype can be quite variable. They tend to be moderately anemic, microcytic. But patients may develop jaundice, splenomegaly. Because of chronic hemolysis, will get gallstones. And they may have similar skeletal changes that you might see like in the beta thal patients. The worst case here is, of course, the 4 gene deletion, where you make no alpha whatsoever, generally incompatible with life. Occasionally, if this is caught exceedingly early in pregnancy, some people will attempt to do in utero transfusions for the fetus to support it through pregnancy, and then once it's born, continue chronic transfusions, potentially do a bone marrow transplant. But most patients are not caught in time, and so it's very, very rare that that would ever happen. All you make is gamma 4, which is not enough to support in utero life. And again, if you can get them to delivery, we would transplant them. We'll skip the gross picture of a hydropic fetus. So we'll shift a little bit to sickle cell, and then we'll try to put all this together towards the end with some questions for you. So sickle cell disease, so this affects millions throughout the world. Sub-Saharan Africa, Spanish-speaking regions. What we forget about a lot in the U.S. is places like Saudi Arabia, India, the Mediterranean countries also have sickle cell disease. So it is not just an African disease that we think about it here in the U.S. But in the U.S., it affects around 100,000 people. Its incidence is 1 per 365 African American births, 1 in 16,000 Hispanic American births, and 1 out of every 13 African Americans carries the trait for sickle cell disease. So this is a point mutation on the beta globin gene at position 6, and it basically causes the globin to be formed differently. We'll show that over here. So basically, in oxygenated blood, all your hemoglobin A and hemoglobin S are soluble, and they're all floating around. With normal hemoglobin, when you're in the deoxygenated environment, like in the capillaries, your hemoglobin A is also floating around. And hemoglobin S, when the oxygen tension is low, these form polymers that sickle and cause the red blood cell shape to change, and that causes the symptoms. Cells with sickle hemoglobin are very short-lived. They're very fragile. They get stuck in the microvasculature. So the normal red blood cell lifespan is about 120 days. In sickle cell, it's somewhere in the 10 to 20-day range. So they are constantly having to make red blood cells to keep up with that destruction. Similar to hemoglobin S genetically is hemoglobin C, so at the exact same place on the beta globin gene at position 6, a different mutation will cause hemoglobin C. Hemoglobin C is toxic to red cell membranes and does cause some hemolysis. It tends to be West African descent patients. And if you have a heterozygous state, so hemoglobin C carrier or hemoglobin C trait causes no disease whatsoever, it's completely benign. When you see it in combination, so you've got 2 copies of hemoglobin C, that's disease. It's not very common, tends to be a mild hemolytic anemia. And we'll talk in a second, the bigger problem is when this gets combined with the sickle cell mutation. So sickle cell, classically, you think about having 2 copies of the sickle cell gene, so beta S, the second one down. As a carrier, you have 1 copy, that's the first one. But you can also have these kind of combination problems, so you can have 1 S and 1 C, so that's hemoglobin SC disease. You can have 1 S with a beta thalassemia gene, so beta naught or beta plus, and those give S beta thalassemia presentations, and they're all a little bit different. Okay, so let's shoot to some questions for a second. So, based on this electrophoresis, this will be your favorite question, I'm sure. The patient has which disease here? This is a normal patient. Sickle cell trait, sickle cell SS, SC, S beta thal plus, S beta thal naught, or impossible. All right, very good. Most of you got this one. So this is SS disease. So you've got a lot of hemoglobin S. And then, again, your body can make some of these alternative betas, so it can make that delta and gamma a little bit, which is why you have some A2 and F. But otherwise, that is a typical SS. Next question, number 4. The patient has which of the following diseases? So same thing, normal, sickle cell trait, SS, SC, etc. So again, you've got 40% of S and 50% of C and a little bit A2 and F. Great, very good. All right, so the next one, a little trickier. So the patient has which disease? All the same options. So here you've got equal amounts of S and C, 45% and 45%. I want to pull our, there we go. Okay, so 45 and 45. You've got a little bit of F, a little bit of A2, and some normal A. What disease is this? All right, so this is a tricky one. So this is the G does not exist one. So having S and C looks a lot like hemoglobin SC. The problem is when you've got those, there's no way you can make hemoglobin A, right? So both of your beta genes that you would need for hemoglobin A have mutations, so there really can't be any A. With that A there, it's really an impossible situation. I doubt you'll get that one on the boards. Okay, so the severity of sickle cell depends on how much S there is. And then kind of along with that, how much A and other things that are good do you have? And there's a lot we know about what makes you sick in sickle cell, and there's some stuff we don't know that makes you sick. So of the following choices, which of these is apt to be the clinically most severe disease? So which of these do you not want the most? Alpha-thal trait, SS disease, S-beta-thal plus, SC, S-beta-thal beta-thal minor, or C disease? Great, so so B is definitely the worst one on the list. And we'll talk a little bit about the differences in types of sickle cell, but the SS version, or S-beta-thal not, are the worst, whereas SC and S-beta-thal plus tend to be more mild variants, and certainly are better than the other ones that are there. So the classic hemoglobin SS disease, where you have 2 copies of the abnormal beta S gene, you don't make any normal hemoglobin A. You'll have kind of normal range A2 and F on the electrophoresis. The MCV tends to be normal, so SS shouldn't be microcytic. Something else is going on. They tend to have a pretty low hemoglobin. Baseline is usually around 6 to 8. And patients have at least a moderate amount of disease, if not severe. Sickle cell is really a horrible disease. The life expectancy for men is in the mid-40s, for women a little bit more than that. But this is absolutely a life-limiting disease. When you've got S-beta not, it's very similar to the SS because you're not making any normal A. The big difference you might see on the blood smear is the MCV is low. So you've got that beta-thal, you're going to have a low MCV. But hemoglobins tend to be about the same. It looks in the clinics just like an SS disease patient with moderate to severe disease. When you make a little bit of beta, so S-beta plus, these patients really tend to do pretty well most of the time. You've got that extra A2 and F, just like you would with a beta plus thalassemia. The MCV is low, just like a beta plus thalassemia, but they tend to be more mild to moderate disease. So these aren't the patients that are always in the hospital for the most part. And then again, if you've got S combined with the C, that's hemoglobin SC disease. Again, you don't make any normal A. You'll have normal A2 and F. MCV here is normal, so C doesn't make you microcytic. You're mildly anemic. And you tend to have, again, mild to moderate disease. They can have severe complications. So sometimes we get falsely reassured they're SC, they're going to be fine, but we can still see severe problems occasionally. They tend to live longer on average, so into the 60s instead of 40s. And for whatever reason, eye complications and bone complications, so retinopathy and AVN, tend to be worse in the SC patients. But some of the other things like stroke and chest syndromes are better. So here we're going to look at some hemograms and try to figure out what's the most likely hemoglobinopathy. So we're going to try to put all this stuff together a little bit. So based on this, what's the most likely? SC disease, H disease, SS, S-beta thal null, beta thal trait. So you've got a red cell count that's kind of normal range, low end range normal hemoglobin, normocytic, retic that's a little bit elevated. All right. Okay, so this is SC disease. Again, in SC disease, your hemoglobin is going to be normal or low end of normal. They're not microcytic. So the beta thal trait, so I think that was the third one people had picked, right? You should be microcytic for that one. This one is not microcytic. So any of the beta thals go away with the normocytic hemoglobin. And then again, in hemoglobin H disease, you should be really profoundly anemic. And SS disease should be more anemic than this. So we'll contrast to this one. So same options. Here, the red cell count is low, hemoglobin is low, MCV is still normal, platelet count's up a bit, and the retic is much higher. All right, so I did a little better. Good. So this is SS disease. So again, contrasting to the last question, we're still normocytic, but lower red cell count, lower hemoglobin, and more reticking. So this is typical of a more severe disease than the prior case. All right, question 9, same options, or similar options at least. So here, the RBC is minimally low. Hemoglobin's normal, or low end of normal. MCV here is low. Retic is up a little. So I think I would go off that low MCV and try to pick your options based on that. All right, great. So this is S-beta thal plus. So again, microcytic tells you this, of the options here, it's going to be one of the beta thals. And again, the beta thal plus is a little bit less severe than the beta thal null. So that higher hemoglobin suggests a less severe disease, S-beta thal plus. All right, so sickle cell, again, a very bad disease. It's a chronic illness, slow deterioration of many organ systems. Really not something good to have. So some of these things are acute problems. So you can have acute chest syndrome. We'll talk about all these. Dactylitis. You can have vaso-occlusive pain episodes. You can see priapism, bone infections, retinal hemorrhages, sepsis, splenic sequestration, and strokes. And then there are many chronic problems we see over time as well. Avascular necrosis. Chronic anemia can lead to cardiomegaly. They have delayed growth and delayed puberty. Their kidneys don't work well, so they often have nocturnal enuresis. Again, chronic pain can develop. They can get pulmonary hypertension. And in patients who are chronically transfused, iron overload is another problem we have to deal with. So symptoms usually appear not until 6 months of age. And the reason for that, right, is in utero you're making fetal hemoglobin. So it's not until that switch happens and you start to make adult type beta hemoglobins and get that beta S that you start to have problems. So over time you get less fetal and more S. And usually if you do a blood smear by 6 months, you can start to see evidence of hemolysis. And overall, painful vaso-occlusive crises tend to be the #1 problem people talk about, but it's not the one that causes decreased life expectancy. So again, in the deoxygenated blood, those sickle hemoglobins start to polymerize. They cause the red cell shape to deform, and then they get stuck in the microvasculature. So vaso-occlusive crises, so this predominantly is bone pain. Typically it's the long bones, back and chest, where you've got lots of marrow space. It tends to be bilateral symmetric disease, so pain in one spot may not be a vaso-occlusive crisis. You can have sickling in the abdomen that might mimic a pancreatitis. It might mimic cholecystitis, which is a problem for these patients because they hemolyze chronically. It might mimic appendicitis, and of course appendicitis can happen in sickle cell, so you can't rule it out. We often don't know what triggers these sometimes, but Dehydration often does. Cold does. You'll hear a lot about weather changes, menstrual cycles, patients who are fatigued, if they're infected with something, stress in general may trigger this. But finding a cause isn't necessary to make that diagnosis. They may or may not have fever. They may or may not have a white count. And you may have evidence of more hemolysis than baseline on their blood smear. The treatment predominantly is hydration to again, reverse the dehydration that often triggers this. Aggressive pain control, so usually it's combinations of opiates plus nonsteroidals. Heat may help to draw in more blood flow to the tissues and dilate the microvasculature. And these last for a while, so usually around a week or so. You can kind of tell patients they're going to be stuck in the hospital when it's a really bad episode. And then the pain may get worse at night, so kind of careful with decreasing pain medicines overnight in these patients. When this happens in an infant or toddler, we call it dactylitis. So in young babies, they have a lot of marrow space in their fingers and toes, and so that's where you get the vaso-occlusive episode. So they'll present with puffy hands, fingers, feet, and toes. And that's often the first manifestation of sickle cell disease if you didn't already know they had it. And again, it can happen as early as 6 months. It's rare after about 6 years because, again, all your hematopoiesis goes to your axial skeleton. Again, hydration and pain control gets better on its own. Usually no sequelae. But if they're really anemic or have a really high white count when it happens, that may suggest they're going to have a pretty bad sickle cell course in general. You can sequester blood in your spleen. And so usually that presents with rapidly worsening splenomegaly and a drop in the hemoglobin. This can be life-threatening. Mortality for a first episode, if not treated quickly, can be over 10%. Patients can have multiple episodes of this, which is frustrating. So once it's happened, you have a 50% chance of recurrence in the first couple months. And usually sometime in the toddler age is typical for this. May be triggered by infection. Usually it's SS patients. In SC patients, we tend to see this a little bit later on. So it's really important. We can actually teach patients how to palpate spleens or teach their parents how to palpate their spleens. And so sometimes we'll get a phone call that they tell you the spleen feels big, and we'll bring them in just for that. Usually we'll treat them symptomatically. If they have a really big spleen, you want to fluid resuscitate, we give gentle transfusions to compensate. And when it's life-threatening or if it's happening over and over again, we may take the spleen out to try to make that better for them. You can see aplastic crises in sickle cell. So this is the kind of typical Parvo B-19 infection in a sickle cell patient. So again, the lifespan of a red cell in sickle cell disease is really just a couple weeks. And so if you get a virus infection that attacks the bone marrow, most of us would tolerate that because our blood lasts longer. In sickle cell disease, those blood cells disappear very quickly. They have precipitous drops in their hemoglobin and can present with symptomatic anemia. Really, we get them through this by giving transfusions when needed. The trick here will be most sickle cell patients have a high reticulocyte count here. When that retic count is low, that should be a tip-off they have this. The infection might have happened 2 weeks before you see them, and so they might not remember the history of fever or rash that might come with the parvovirus. And just a quick little diagram. So this is normal situation, which is you make blood slowly and you lose blood slowly. And then in the sickle cell patient, you're losing the blood very quickly. So again, if you turn the faucet off, so if you get parvovirus, most of us, the tank stays pretty full. And then in sickle cell disease, you turn off the faucet, and they drop very quickly. When you have vaso-occlusive episodes in the chest, you can have acute chest syndrome. This is really a severe life-threatening problem. Basically, it's determined by having fever, respiratory symptoms, and pulmonary infiltrates. So here you can see there's a couple vague infiltrates in the chest here. We see this mostly in SS or S-beta not thalassemia. We see it less often in SC or S-beta plus, typically in younger kids, but really happens throughout the lifespan. We see it more in the cold and flu season. There's probably some viral triggers for this. If you've recently had a surgery and you're not taking big breaths because your belly hurts or your chest hurts from the surgery, that can predispose to this. And then the clinical course of this, usually they can become hypoxic, they can develop respiratory failure, you can have worsening pulmonary edema. When this happens many times, you get scarring in the lungs, and they can have chronic lung disease. And patients who have a history of recurrent ACS is certainly associated with a high mortality. We don't exactly know what causes it all the time, so it may be from just direct sickling in the chest. There's some thought that you may get fat embolism from sickling in the marrow that then travels to the lungs. Again, you may hypoventilate because of pain or narcotics, or fluid overload may also trigger this. There may be infection going on. These patients may have asthma that triggers it and other things. So when it's really mild, we can sometimes just watch it, give a little bit of hydration, make sure they're oxygenating well. We usually cover for infection, even if we don't find it, so usually that involves kind of typical pneumonia therapy, and we often will cover for atypicals. And then gentle transfusion is usually what we'll do, but sometimes when it's severe, we'll also give a exchange transfusion. These patients may need to be in the ICU. They may need to be intubated. Infection is a big problem in sickle cell disease. There's a decreased immune response to infection. These patients are functionally asplenic from recurrent vaso-occlusion in the spleen, and that really leads towards encapsulated organisms. The reason we do newborn screening in the US in every state is actually to prevent infection, because sometimes what would happen before we did that is patients would present at 8 or 10 months of age with pneumococcal bacteremia and be very ill from that. And so now we can prevent a lot of those infections. So they can be bacteremia, they can have pneumonia, we can have osteomyelitis, which may be staph or it may also be salmonella. You can have stroke from sickle cell disease. So these are actually large vessel strokes and really can be very debilitating when they happen. We monitor for these by doing blood flow ultrasounds on the head called transcranial Dopplers. And when those numbers start to go up and suggesting the blood vessels are getting narrowed, we can actually try to prevent stroke by putting patients on transfusion regimens. Strokes happen early, so the median age is around 5 years. They certainly can be fatal. When they're not, they can lead to severe disability. And then kind of chronic sickling in the cerebral vasculature, you can lead to a moya type disease, which also can be a problem. They can have aneurysms. So when this happens, really the standard therapy is to exchange transfuse these patients. So you want to get their sickle fraction as low as possible. So the goal is to have it under 30%. And then more chronically, once they've had a stroke, we want to prevent more strokes because there's a very high recurrence rate. And so these are patients that will go on regular transfusions to keep the sickle fraction low. There's emerging data on what happens if you've got, we call silent strokes, where you find it on an image, but they have no clinical correlate. It's a little unclear what to do with those patients. Sickling in the bone over time can lead to avascular necrosis. Sometimes this requires joint replacements later in life. Priapism is certainly a very distressing problem. It can be very, very painful. The penis sometimes needs to be aspirated to get the erection to go down. And long term, there's usually sexual dysfunction from this. So this is really a debilitating problem. And often once you have it, it tends to get worse and worse over time. So things we can do to help keep people healthy with sickle cell disease. So in 1973, the average lifespan was 14 years. It is much better now, but not perfect. So neonatal screening. So if you see evidence of sickle cell on the newborn screen, those patients come to a hematologist or a sickle cell referral center so that we can define what kind of sickle cell they have. Patients really should be treated at a comprehensive sickle cell program. There's a lot of anticipatory guidance. But again, one of the biggest things that we've done is started antibiotic prophylaxis for these patients. So again, we want to start by 2 months of age. We continue it at least until 5. The gold standard is penicillin. A lot of people use amoxicillin. They probably work equally effective. So before newborn screening started, the mortality from sickle cell was 25% by age 4. So we have significantly improved that. This slide's a little dated, but certainly we want to give immunization. So patients to be up to date on their pneumococcal vaccines. They should get the polysaccharide vaccine as soon as they can. We now also have meningococcal vaccine approved into infancy, and so we give that to patients now too. Patients that have yearly influenza vaccine to prevent flu. We do start folic acid, like Dr. Gowans mentioned, in these chronic hemolysis patients to make sure they can continue with the red cell production. When they get fevers, we treat them aggressively because we don't know if that's going to be a bacteremia, especially at younger age. Patients who go to surgery, we make sure to do transfusions ahead of time so that they're not sickling in the lungs post-op. And we follow very regularly. We check heart studies, we check these transcranial Dopplers to screen for stroke. We have regular eye exams to look for retinopathy. And again, patients who are having disease burden chronically with sickle cells, we think about doing chronic transfusions. So when we transfuse these patients, they need sickle negative blood, ideally, because you don't want to put more sickle cell back into them. It's also very easy for patients to get antibodies against minor red blood cell group antigens. So we try to do extended matching on the blood cell products. And when you do transfuse patients, they often end up with iron overload. So then we're looking at chelating to try to get the iron down and not cause a long-term hemochromatosis. Other things we can do, so hydroxyurea is really the mainstay of therapy for sickle cell. It's actually indicated down to 9 months of age now, so we really try to start these patients very early. It's a little unclear exactly how it works, but it does increase fetal hemoglobin production, which then decreases your sickle hemoglobin production. But there's absolutely benefit in terms of reducing pain, hospitalizations, transfusion need, chest syndrome, et cetera. The FDA just approved about a month ago also glutamine for sickle cell disease, so there's one brand out there that has labeling for this, but that's also been shown to reduce sickle cell complications, so we have a total of 2 drugs for sickle cell now. Really, for patients who are very symptomatic, we do think about bone marrow transplantation. And it's right now the only approved curative therapy for sickle cell disease. What's really tough is you got to find a donor. So even with lots of full siblings, is each one carries a 25% chance of being a match. So most patients with sickle cell disease do not have a match. And so trying to figure out who we transplant with alternative donors is very tough. There's also work going on right now for gene therapy for sickle cell disease, which will hopefully improve this for a lot of patients. Okay, so I've got a few questions out of the way here in 5 minutes. All right, so the mortality rate of splenic sequestration has fallen over the last 10 years, and why has that happened? So patients are started on folic acid, higher doses of penicillin, better diet, teaching patients to palpate a spleen, or admitting for 48 hours every time they have fevers. What reduces splenic sequestration risk? Great, okay, very good. So you're on call, and you're asked to see a patient with SS disease. He's admitted 2 days ago for a fever. Oxygen requirement is increased up to 5 liters. Here's his x-ray. What are you going to do next? So you're going to give Lasix, you're going to intubate, you're going to transfuse the red cells, you're going to get a stat head CT, or you're going to call 911. All right, so we're going to do some sort of transfusion. Right, so whether or not you do a simple transfusion or an exchange transfusion is sometimes a bit of a complex answer, but you have to get healthy blood into that patient. Okay, question 12. A patient with hemoglobin S beta naught comes to the ER, has left-sided weakness. And the choices below, what's the least appropriate thing? You get a head CT, you do an exchange transfusion, you contact the hematologist on call, you give fluids, or you dilute the sickle fraction by giving by transfusing to a hematocrit of 36. Great, yeah, so really one of the most standard indications for a full exchange is acute stroke. So we don't want to try a simple transfusion. It's not going to get the sickle fraction down enough. We really have to exchange for an acute stroke. All right, a mother gives birth to a premature hydropic baby due to thalassemia. Okay, think back to thalassemia. Of the choices, what is the most likely ethnicity of the parents? So a hydropic baby with thalassemia, think about what kind that might be. Are they African American, Chinese, Greek, mothers from Mars, fathers from Venus? Both parents are Indian. All right, so this is the Chinese is the answer here. So again, this is the Chinese or Southeast Asian variants of the alpha thal deletions or the cis form and over there, so more likely to be Chinese to have a 4 gene deletion. Okay, a 2-year-old boy comes with the following blood count. What does he have? Dehydrated, TEC that Dr. Gallons had talked about, thalassemia, autoimmune hemolysis, or iron deficiency. So there's a little bit of a low RBC, hemoglobin's a little low, MCV is normal, RDW is sort of in the middle, and has a kind of normal retic. This one's a little tough. right, pretty good. All right, so this is TEC. Kind of the trick here, right, is the normocytic part, so that's going to rule out your thalassemia and your iron deficiency. In autoimmune hemolytic anemia, you should really be reticking very briskly. And so in this patient, the retic is present, but it's not where it should be, and certainly not as high as we would expect in autoimmune hemolysis. And then dehydration, if anything, should make your hemoglobin go up a little bit, not down. All right, a 2-year-old comes in with the following blood count, most likely diagnosis, same options. So here, the RBC is a little bit high, hemoglobin is low, MCV is low, and the retic is a little bit elevated. All right, so the C is the answer. It's a little bit split. But yeah, so this is a thalassemia. So the iron deficiency is the big toss-up here. And the reason is really not iron deficiency. So the RBC count is high, so in iron deficiency, you would expect that to be low. And then with iron deficiency, you're really not making red cells. So the fact that the child's got a decent retic count in the kind of normal or high normal range really suggests that they're making blood cells, so it takes away the iron deficiency. We'll skip over this one real quick just in the essence of time here. So this one, so in 16 is the iron deficiency, so the difference, of course, is the low RBC and the retic count that isn't quite as high as before. And then our last question here, we'll just go through it real quick, but in this one, you see RBC is a little bit low, hemoglobin's low, MCV is normal, and retic is quite high. So this is the autoimmune hemolytic anemia, again with a very high retic. That's what we'd expect to see. And then at the end of the handouts for you as well, just a few things you can look at in your leisure, but kind of just goes through some of the salient features for the hemoglobinopathies, thalassemias. All right, thanks.